In this video we're going to talk about a classic socket preservation case I performed for a patient in his mid-30s. So this patient was referred in for 2 failed root canals on his upper right 4 and 5. So you can see here that he's got pathology across the apex of both of these teeth. His smile line is high, so his aesthetic requirements, even though these are on the side of his mouth, are still high as well. And being a young patient, he wants something that's predictable and long-lasting. So being a referring dentist here, I'm only going to be treating the 2 teeth in question. We have, of course, seen and noted that there is caries on the upper right 6, which his own referring dentist will crown in time. So here you can see my concerns when planning the case. Once I've removed the upper right 4 and 5 teeth, the residual sockets, even after thorough degranulation, are very large. I'm not so sure many dentists would feel comfortable trying to get primary stability and reinserting an implant into each of these sites. In the upper right 5 site, for instance, you can see there's a very, very large hole, and in the upper right 4 site, the only minimal bone engagement you might get, you're basically going to have to drill through. So here I performed socket preservation with 2 cc of ethos. However, as you can also see, we were unable to get primary closure from the initial mucosa or tissues. So here in this case, we've also sutured over some collagen membrane. What we're trying to do is basically act as a bandage or plaster to contain and retain the ethos mass, because understandably it is a particulate and it will escape into the mouth over the coming weeks during healing. In this case, I left the case for 3 months or 12 weeks. Most cases now I leave for about 10 weeks. But as you can see upon re-entry, the 3D volumetric bone regeneration is fantastic. He's really maintained that 3-dimensional structure, which then makes this a really predictable, easy case to then, of course, place our 2 implants. So you can see here how the bone upon radiographic evidence is still looking like a particulate, but you can see upon visual re-entry, the bone is bleeding, it's vascularized. Yes, there is still some particulate, but we know that under a biopsy, ethos takes about 1 year to completely regenerate. So yes, it's still in that immediate early turnover phase, but it's good enough for us to place our implants and achieve good primary stability. So once the implants have gone in, we then still wait our conventional protocol of another 10 weeks. Once the 10 weeks have taken place, we can then of course restore the implants with 2 single independent zirconia crowns in this case. Here of course we will place screw retained Atlantis abutments. And again, we note that the upper right 6 will be restored by the referring dentist. These photos are taken immediately after crown insertion. However, we know that over the next 2 to 3 weeks, the soft tissues will continue to mature and shape and mold around the cervical neck of each of these crowns. As you can see here, the aesthetics are satisfactory for the patient, and at his age, in his mid-30s, it should give him good long-term predictability. This next case, we're going to learn about socket preservation, which actually rebuilt the bone outside of the existing bony envelope, trying to rebuild almost what the patient would have had back in her teens. Bearing in mind this patient is now in her 70s. So here we have had a patient suffer from periodontal disease. As you can see, the teeth have been historically splintered together in hope to try and retain some stability, but we have accepted now that the teeth are on their way out. So after careful planning, we decided to do socket preservation. We weren't quite sure there would be much, if any, of a buccal plate left. As you can see, once we've carefully and atraumatically removed the lower 4 incisors and raised a flap to have a physical look, and after thorough degranulation with hand instruments, there is definitely a lack of buccal plate. And yes, I could have definitely placed some immediate implants, but they would have had to be placed quite deep. So the thought process was here to rebuild with 1.5 cc of ethos and then place a collagen membrane over the top and place simple interrupted sutures to close the wound. As you can see here, once you've dried out the ethos, the wound knits together quite well over the top. But the beautiful thing is 3 months later, or again only 12 weeks, upon re-entry, you can see the bone is hard, it is vascularized, and the particulate is turning over nicely into new bone. But what the difference is, the 3-dimensional volume has been immeasurably rebuilt and regained. And so this turns what was either a deep immediate placement or a slightly unpredictable buccal plate rebuild into a really straightforward, nicely planned implant case. So as we follow through our standard implant protocols, place 2 implants in the lateral sites, you can see how there's nice bone buccally around both implants. And then of course we place healing abutments, so single stage surgery, and place some more sutures, of which you can also see we've got some really nice thick keratinized buccal tissues. Looking at the implant placement radiographically, we can also see that there's an abundance of bone regeneration both over the crest of these bone level implants and buccally. Again, upon taking impressions at 10 weeks later, we can see you've got nice thick keratinized tissues, but also a nice 3D bony contour of the anterior area of the lower jaw. And of course we place a screw retained bridge with Atlantis abutments, and again this case has become really quite predictable, and we've got a nice restorative platform and nice implant depths. So again, it has just been a wonder to use from what was potentially a slightly challenging case to a really predictable, nice workflow. This next case was referred in by his referring dentist as potentially an impossible case. The patient was not expecting me to even consider placing an implant here, and to be fair, looking at the OPG or radiograph, we can see that the extensive bone loss even extends right down to the inferior alveolar canal, and so understandably we may not be able to curette out this infected socket completely. So the methodology here has been slightly different to the previous cases. So what was lovely to work on this case was, you look at it and think, wow, that's a big defect. I don't know if an implant would even be possible here. But actually, after we completed the workflow, it was one of the simplest cases I have performed. This patient was referred in for an periodontally infected lower left 7, slight mobility. The only bone remaining on this tooth was the mesial root. As we can see, the pathology extended right around and underneath the distal and into the furcation, and right down to the inferior alveolar nerve. Clinically, however, everything looked fine until you started probing the tooth, and then the probe literally just disappeared right down to the hilt. And as we can see, once we've carefully and atraumatically removed this tooth, you can see how dirty with calculus right until the apex of the lower left 7 distal root it was, and this tooth was never going to be saved or cleaned effectively by a periodontist by this point. So if we had taken this tooth out and left it to heal by itself, one, there was a large amount of infection present, and two, the bone volume would have definitely collapsed. Typically we don't just see bony collapse, but we also see infill of the buccal sulcus and lack of keratinized tissue, thus making any potential future implant placements almost impossible. However, here we did do socket preservation, but importantly and interestingly to note, I did not curette out 100% of the socket. As you'll see from the radiographs, we have literally only curetted out maybe the top third of this infection, and actually I left the rest. And I just did a simple relieving incision with maybe 4 sutures just to achieve primary closure, and we left it a traditional 10 weeks. Upon re-entry at 10 weeks, you can see here the 3-dimensional volume and thickness has been retained. It was far superior to what I expected to be seeing when I went back in. And of course you can see the keratinized tissue is still really nicely forming. Understandably, at 10 weeks, the ethos powder is still a little bit soft because we're drilling primarily into the new ethos bone and what arguably would have been the healing granulation tissue. However, it was enough to achieve primary stability and do a single surgery where we placed the healing abutment and placed maybe 3 or 4 sutures on top. But you can also see from these images how thick that buccal tissue is, which is wonderful to see. So here we can see with the working and final radiographs of the implant being placed, even then the majority of the implant is in either ethos or in new regenerating tissue. And as you can see, the before and after results show amazing bone regeneration, and for the patient a wonderful result, where at the beginning his dentist and the patient were really not sure whether an implant would even be feasible, but he's absolutely ecstatic that he has achieved a complete rebuild of his missing lower left 7. So this has turned a potentially difficult case into a very predictable case, as you can see.